So,
Okay. All right, we're playing. So Arun is going to be our actor, and Mr. Mummy is our patient.
Mr. Mommy, I'm just going to suction your trach, make you cough.
Okay, and so Arun's going to show us the proper technique. As you can tell at first, he is fully protecting himself with purple gloves, a yellow gown, and a full face shield that has the plastic up top to prevent eye splash. Now he has his sterile gloves, which he's going to open and remove his dirty gloves to put on his sterile. He has one for a clean hand, and as he reaches under to remain in the sterile field, as you can see, he keeps that sterile by wrapping it around his hand to prevent it from touching the patient or touching the bed. He removes the trach collar to give easy access to the trach. And then you keep your bag and bag the patient several times. Our suction has already been turned on to 120 to 140, and the tubing has already been attached to the catheter. Now he goes down slowly and twist the catheter down while applying suction and slowly suctioning both in and out until the patient coughs. Replaces it again and gives some breaths, always keeping an eye on the saturation. And for this type of patient, a lot of times the suctioning, the passing of the catheter is mostly the uncomfortable time, and so if you have as long as 15 seconds to remain down there. So what you want to do is keep it down there and just kind of suction for a good while, let them cough, feel how much secretions you're getting, take your time, be slow and persistent, and then return the patient back to oxygen. All right, thank you. I'm going to do a quick troubleshooting scenario where, let's say you come in, the patient is in distress and not oxygenating well. Every room will have a ambu bag attached, so you want to go ahead and make sure that you turn that to flush, and you bag the patient. But let's say in this scenario that you can't get any air movement, the chest won't rise or anything like that. Your first thing that you should do, because the most likely problem is that the inner cannula has been plugged. And so what you want to do is you want to remove the inner cannula by squeezing the two tabs that are on the side there, and then you want to slowly remove it, just like Arun did here. There's always going to be spare inner cannulas, either right next to the head of the bed or in the first drawer under the TV set. And once you you open up the new inner cannula and you insert it and squeeze those tabs and push down, and you'll hear them click. And then that should free up and allow air movement, and then you'll still want to go ahead and go down and suction as normal. We're going to skip ahead, but let's just say, and then you want to suction as normal so that you can go ahead and make sure that it's a patent airway. But this is something that obviously you'd be calling the respiratory therapist as well, but this is something that every clinician needs to know about, as this could be a life-saving troubleshooting technique. Thank you. Arun's going to walk us through now an inline suction technique. This is with the vent, and it's a closed suction system. So you have, first off, the suction port. It can be locked. You'll see that white cap that goes back and forth. So once you get it to where you can push it down and cause the suction, as you see, Arun is holding the trach in place with one hand and then slowly going down with the other hand. And then once he's down, he holds it again with that other hand and slowly pulls out while holding down that button. So we'll do it one more time. as you have one hand that just kind of uses two fingers to keep the trach from moving, because that's kind of what's painful for those patients. And sometimes if he meets a little bit of resistance, he has to kind of twist the catheter down that first couple inches, but then once it's down, you go ahead and you allow the patient to cough, support the trach, and slowly pull out while suctioning. All right,
Pull out to the black mark.
And you want to pull out to the black mark. That prevents that sometimes that you've fully exhumed the catheter. And all of these should remain attached to the suction, and it'll be set up in a way where it's hanging on the arm of the ventilator, and this prevents pressure on the flange of the trach, and also easy access so that anyone can do it. All right, now we're going to quickly talk about the servo. Walk around. And some of the alarms that you may see. So the alarms panel up top is where you'll see the alarms. So your high pressure or low pressure alarms will be seen here. Those are two that are easy to catch. High pressure means that there is an occlusion somewhere, so that may be that the patient needs suctioning, or that there's the tubing is stuck in the bed, something of that sort. Your alarm button is in the top left corner here, and that will give you 2 minutes on that alarm, but that alarm only. Let's say that there is a disconnect somewhere, then you'll get a different alarm. And that, if check tubing, something like that, that is when a patient may have either taken themselves off the vent, or that a part of the vent may have been disconnected. So that's something where you just want to check the circuit, and if it's an obvious something that's fallen out, then you'll put that back in place. And lastly, if you are going to suction the patient, or there's a situation where the patient is desatting and the RT is on their way, you can hit this O2 breaths, which is down in this corner, and that will automatically bring the patient to 100% oxygen. So, all right, thank you for your time.